And this is a quick video to help you before you take your exams. If in case you take your exams in a week or two, I feel like, and if you're not taking your exams, you should listen to this. When you get closer to your exams, you should do the same strategy. I know you guys have done a really good job studying and everything, but when you're getting closer to your exams, you should be thinking in a bi-directional thinking. What does that mean? Well, if they give you a subject, there's always sometimes most of the topics or content that you guys study, a few of them, like maybe 30% of them, as either a problem that there's something that is high or something is low. Okay, either there's positive or negative, or there's anticholinergic and cholinergic. All these things you shouldn't be studying them in isolation. You see medication. They will say this medication has a cholinergic effect. Later on, you see another medication. It has anticholinergic effect. I think you should put it together and start thinking bi-directionally. And this is an example of it, a bi-directional thinking and diagnosis. We have here a couple of diagnoses, okay? Um, and so we're going to use that to answer this question. So they give you SIDH and DI, okay? Don't separate them. When you learn them, write them on a piece of paper. If I have SIDA, the opposite is DI. If I'm more comfortable with the SIDH, I'll study it really well. And the DI, I know a little bit about it. But then when they ask me about DI question, I know it's opposite of SIDA. So whatever I expect is what is going to happen. So like this one. So this is, and try to simplify situation. Your exams, there's so much information. Simplification of content make things easier. That's what I try to do in this channel. My videos, I try to simplify, give you the key pathophysiological understanding, and you use that to answer the question, to use that to find risk factors. You can use that to find the teaching and the content level. So for this one, what I'm going to tell myself is what? Increase ADH. That's all. I'm telling myself increase ADH, okay, will lead to what? There's three things I'm going to write, okay? What is going to happen? Concentrated urine. And then concentrated urine, I have what? Fluid overload. That's all. Fluid overload. So fluid overload. So for my SIDH, it means I have increased ADH, I have concentrated urine, and fluid overload. I'm not going to list all the symptoms that is expected. You can use these three to answer it. You can use concentrated urine to answer specific gravity question. Then if they give you DI, well, if you write this, you just say opposite. If you know SID, well, just write it SIDH, and it said, okay, they asking me for DI. So I should have lower ADH, I should have diluted urine, and I should have fluid deficit. And then the rest of the information should follow through. So no, you think about it about directionally. And if you do that, success will be yours. Don't separate them. If you want to learn all the symptoms, that is fine. But when you're getting closer, try to like think bi-directionally. Don't study SIDH without studying and leaving DI and study it tomorrow. Like study it together and say, okay, this is opposite that. If I see this and they ask me this, if I know this well, I can write this one well, and I use it to answer the other question. Same as this one. Okay, I have cholinergic and anticholinergic. Well, which one you want to choose? Do you want to choose cholinergic or anticholinergic? I know cholinergic means I have too much acetylcholine. So I have too much acetylcholine. And what will happen? Where urine output will go up, I will have diarrhea, I will salivate more, I will have constricted what? Pupil, okay? Right? If you, I don't want to keep on listing the symptoms, right? You can list all of them. You can have anything you want to, whatever symptoms you want to list, but these are cholinergic. Therefore, if they ask me to talk something about anticholinergic, a medication that has anticholinergic effect like TCA, and I know cholinergic, I just list them and then rewrite them in the opposite way by directional thinking. Similarly, hyperthyroidism. How can you make it simple? Simple, where you have high thyroid hormone on one of them. Okay, high thyroid hormone. And what would it lead to? Well, everything is up. So everything is up. Therefore, I have tachycardia, okay, palpitation, temperature is high, you have diarrhea, and except the only thing that it goes down is weight loss, okay, because of the increased metabolic um, um, rate of the hyperthyroidism. And you see what I've done? A few of them, because those are the key, those are the pathophysiological features, a key of them. Therefore, if they ask me something about hypothyroidism, in my head, I know it has to be opposite of that. When I see answers, I'm choosing opposite answers. This is bi-directional thinking as you get closer to your exams. You see what I've done? They're going to confuse you with these guys. They look the same and they have the same symptoms. Malignant hyperthermia, so MH, okay, and neuroleptic um, malignant syndrome and serotonin syndrome. They are almost the same. So you can't separate them when you study. Otherwise, you get confused when you see them. You say, which one is it? Which one is it? The only difference between them is when did they happen. Malignant hyperthermia is usually somebody who just had surgery. They are in the PACU or they are in an operating room right away, operating room still. Okay, that's when their symptoms will present. What is NMS? Somebody on antipsychotic. So he's on antipsychotic. And what is serotonin syndrome? Where somebody on SSRI, like fluoxetine or maybe citrulline. Antipsychotic, you know them. Clozapine or olanzapine, risperidone, a bunch of them. If you know them, he said, okay, what is common about all of these guys? What is common about them? Well, when their side effect, when you have malignant hyperthermia, guess what? Temperature is like over 104. And key symptoms is what? Rigidity. More so the buzzword, rigidity. I'm not going to list all the symptoms because everything goes up. But the two key features is higher temperature. When your temperature is high, 104, I expect you to be tachycardic. I expect you to be sweating. All the symptoms associated with that, you know. Okay. Then the other thing they have is rigidity. Those are the two things. It's because of underlying muscle problem. How did this happen? Patient undergo surgery and they get inhale anesthesia, and they may have family history of malignant hyperthermia. They don't know, and then all of a sudden in the PACU they have muscle rigidity. Their jaw is tight, everything is tight. Temperature 104. That's your diagnosis. But if you don't know, it will confuse you. What do you think the examiner is going to put in the multiple choice? He will put serotonin syndrome there. He will put neuroleptic malignant syndrome. He will even put hyperthyroidism because the temperature is going to be high. What is NMS? Well, that one will be easy. Patient is on antipsychotic and his temperature is also the same. Temperature is 104 and he also has what? Muscle rigidity. You see how they can confuse you. Guess what? Patient on SSRI is the same thing. They go into serotonin syndrome when they combine other serotonin, like MOIH, or take Stephen John's Watt, okay, St. John's Watt, sorry. and therefore they develop excessive serotonin. And this is what happens. Well, guess what? Temperature, they have high temperature, 104, and muscle rigidity at the same time. So how would you know which one is this? It's the scenario. And that is what you have to start paying attention to. Things that look the same, group them together and trying to make it easy for yourself. There's so much things you're learning. It's now time to synthesize it and put it together and understand that, oh, this is not in vacuum. I'm not learning this antipsychotic, all because when you treat patient, you treat them as a whole. When a patient come in with appendicitis, well, he may have schizophrenic, is on antipsychotic, or it may be diabetic, is on other medications, and you have to think it. So think bi-directionally. The same thing. Cushion. Which one you prefer? Do you prefer um, Addison or cushion? Which one you comfortable? This is what I do it. I say cushion, well, too much steroid, too much steroid. That's all. Then I'll say, if there's too much steroid, what is the problem? Well, fluid overload. If your fluid overload, sodium, what causes it? Most fluid overload is associated with sodium is high, potassium is low, right? And then hypertension. Their glucose is high. So glucose is high for cushion. Now, if they ask me Addison, I just take it as opposite. So steady in bi-directional. Addison were less steroid, fluid deficit, sodium is low, potassium is high, they are hypotensive, and their glucose is low. Making things easy for yourself. Same thing, fluid deficit. Which one you prefer more? Which one is more you're more comfortable? You can list your symptoms and then you can use it as a negative or positive. Well, if you like the deficit, if you like the fluid deficit, well, then what do? You say, well, dry mucous memory. You list them. Okay, they can be hypotensive. Okay, their skin is dry. I mean, you keep on listing. I mean, things that you expect them to have when they have fluid deficit. Okay, so and then you use it as a negative for fluid overloaded. So when you're selecting the answer, you've learned both, you've seen them in, this is opposite like that. So you're thinking about it in that bi-directional way. Let's see a few last ones. I put this one there because I know it's very important. Sometimes it's the same thing. What is extrapyramidal symptoms? They like asking that. Well, extrapyramidal symptoms can happen in two places. People who is on antipsychotic or people who is taking nausea medication, antiemetic. And so you have to be able to distinguish between them. And most of the antipsychotic medication causes EPS. But then, and most of the nausea medication does that. The key one for nausea medication is Reglan, metoclopramide, which is Reglan. Okay, that is the one that causes extrapyramidal side effect. But most of them, or that's Zofran or Danistrone, Reglan, promethazine also do that. Promethazine can do that. Scopolamine patch can do that, and Reglan, metoclopramide can do that. You can check my antiemetic this thing video. It's on YouTube. But they also do the same thing. So be able to distinguish in your head which one am I dealing with? Is the patient getting this for nausea or is that antipsychotic? Then you have to know what is the EPS. Okay, the EPS I call it adapt. So EPS is an adapt where they have A is acute problem, usually okay, acute problem, and the D, okay, is dystonia. So dystonia. That means all your muscle tone is affected. Okay. And the other A is akathisia. They cannot stop still. They keep on moving non-stop. And then they have P. They look like Parkinson patients. So Parkinsonism. Okay, so Parkinsonism. So Parkinson. And spelling is getting so they have like symptoms of Parkinson. They have marks, okay. They have face marks. They have shoveling gait. Okay, they lean forward. They have pale rolling, tremor. All of them is consistent with the Parkinsonism. And the T, they have tardive dyskinesia, TD. Okay, tardive dyskinesia. And you have to know what is the tardive dyskinesia. Most of them, they have face, they have grimace face. They have the cheek, the pops their cheek, okay, and then they smack their they they will be licking their mouth most of the time. They'll be blinking unnecessarily. They have tuberculosis, basically turn their neck in some way because of the muscle contraction. They cannot control it. All these things, they blink all the time. They chew unnecessarily without anything in their mouth. These are the things you know, and you put it together. So if I see antipsychotic patient and they're doing this, I know it's extrapyramidal side effect. If somebody is an antiemetic and he's doing that, it's the same thing. And guess what? The treatment is the same thing. Benztropine. That's what you give them so that they can stop doing that or stop the medication. But you see two different class of medication having the same symptoms. And then the next one is myasthenia gravis. So MG, which one you want? Do you want myasthenia? The reason why I put this together is when you treat myasthenia gravis, they go into cholinergic crisis. So which one you want to think about? And when you study, know that they can ask you about cholinergic crisis and they can put it in the select or apply. You know, myasthenia gravis patient, the antibodies to acetylcholine receptors. Therefore, even though they have acetylcholine, they can bind to that. Therefore, they good. I mean, they're strong during the day and weak at night. Okay, they have vision problem, and then bladder and bowel problem. The problem that usually is very important is swallowing. If they have swallowing problem, this is a priority patient. Then when you treated them with neostigmin, okay, you give in neostigmin, they become cholinergic crisis. If you give them too much of neostigmin, now the acetylcholine is high and they have symptoms of cholinergic, which means a lot of saliva, they pee a lot, they have diarrhea, they have constricted pupil, they're sweating a lot, all these things, and they bradycardia, consistent with cholinergic crisis. So almost opposite with what myasthenia gravis people would do. Bidirectional thinking and synthesizing things together. And finally, my favorite. When I see a heart failure question, I feel like it's a free for you to choose it. There's two words for all the heart failure, and they know students get confused with that. Two words. Write heart failure. What does it mean? Systemic congestion. That's all. I'm using one word. Left heart failure. What is that? Pulmonary congestion. That's all. I don't need to worry about anything anymore. What is systemic? Your body system is congested. Well, if my body system is congested, it means I'm fluid overloaded. That's all. That's the symptoms of right heart failure. Therefore, you expect what? JVD. You expect renal, liver congestion. So They have a liver is big, so liver big. You expect edema, all the symptoms associated with fluid overloaded outside the lung. Is if the answer choice involved lung, is not left uh, it's not right heart failure, it's left heart failure. And then when you come to pulmonary congestion, you're just looking for symptoms of the lung. That's all. Okay. They have dyspnea. Okay. They have pulmonary edema. Okay. They have autopnea. I mean, the kidney, all the symptoms that you can think of that will happen with the lung. And I'm choosing answer choice for that. And that is what I want to start thinking, bi-directional thinking, and then put it together like one thing you study, no isolation, so that when you see questions, you can even analyze it and said, oh, fluid overloaded patient. Well, if his sodium is in 135, I think is fluid overloaded. That's why sodium is that low. It can have symptoms of fluid overloaded. It can develop right heart failure, and that can lead you to left heart failure. All these symptoms are interconnected. So, bi-directional thinking. Hope you get this message. Thank you for listening, and subscribe to the channel if you like this, and expect more videos of this content. Take care of yourself, and all the best of luck.